Hello everyone. Today we'll be talking about how to set inspiratory flow rate on the ventilator using volume assist control mode. Our learning objectives for today's lecture is the following. First, we'll talk about what inspiratory flow rates are and what are the normal values and how to initially set up the inspiratory flow rate when you put the patient on the ventilator. We'll talk about two different types of inspiratory flow waveforms. We'll also talk about when do you need to increase your flow rates and what should you watch when increasing the flows. We'll talk about how to optimize inspiratory flow rates. We'll also talk about expiratory flow rate and how to optimize it as well. The inspiratory flow rate is how fast your breath is delivered. In inspiration, you take around 1 to 2 seconds to inspire and around 4 to 5 seconds to expire when you are at rest. So let's take an example. If your tidal volume is around 500 cc's and your respiratory rate is 12, that gives you a breath cycle of 5 seconds. And let's say your inspiratory time is 2 seconds and your expiratory time is 3. So your flow is 500 cc's in 2 seconds, and that would give you in liters per minute around 15. If you're climbing up a flight of stairs, your flow rate certainly will be much higher. And let's say, for example, your inspiratory time is 0.5 second, your flow rate is 1000 cc's per 0.5 second, and this would come out to be around 120 liters per minute. If you ask somebody who has just climbed 4 flights of stairs and you ask them to breathe slowly, they would become very uncomfortable. And this is one of the things that we'll talk about on the ventilator, something we call flow asynchrony. So how do you choose your initial flow rate for your patient? Well, you have to observe how your patient was breathing prior to intubation. If the patient is breathing comfortably, for example, the one you have intubated for mostly for airway protection, for example, opiate overdose, you can use a normal flow rate around 20 to 30 liters per minute. If the patient is uncomfortable, tachypneic and dyspneic, you start at a higher flow rates between 60 to 90. You can go higher than 90 as well. One of the things to remember is if you're breathing fast, your flow should be fast as well. One of the things before we start is different ventilators give you different parameters to control the flows. Some would give you just the inspiratory time instead of flow rate. Now these two are the same. The flow rate is nothing but your tidal volume divided by your inspiratory time. So you can say that your inspiratory time is nothing but your tidal volume by flow rate. So it is very important to see what your ventilator allows you. If it allows you to change the inspiratory time, the things are much easier because when you drop the I time on these vents, your flow rate increases. On the vents who have flow rate as a parameter, if you increase the flow rate, the inspiratory time will decrease. There are two types of waveform in volume assist control. One of them is your square waveform and the other is your descending wave. Descending wave is more commonly used as it's more comfortable and results in lower peak pressures. However, square waveform gives you shorter I times. It's important to understand that the peak pressures for both these waveforms would be different. The square waveforms give higher flows and hence higher peak pressures. However, the plateau pressures would remain the same in both the condition. Whenever you are looking at the peak and plateau pressures, you want to change the flows to square waveforms. Well, there are two conditions when you think about increasing the flow rate. First is when you have to increase the expiratory time, and that you can do by increasing the flow so that your I time is decreased and you give patient more time to breathe out. And the patient wants higher flow rate or is flow hungry. It's also called flow asynchrony. We just talked about when you climb the flight of stairs and you ask somebody to slow down on the breathing. You increase the flow rate to decrease the inspiratory time. So let's take an example. We have a patient who is on a rate of 30, tidal volume of 500, and his flows are 30 liters per minute. That gives you a one breath cycle of 2 seconds. And if you divide your tidal volume by flows, you will get your inspiratory time, that is around 1 second. And this gives you an expiratory time of 1 second. If you double up the flow to 60 liters per minute, you drop the I time to around 0.5 second, and the extra 0.5 second that you obtained from your inspiratory time now goes towards the expiration. Similarly, if you triple the flow, your E time would be even longer. Hence, to increase the expiratory time, you want to decrease the inspiratory time. On the vents that have simply inspiratory time as a parameter, these things are much easier to do. So let's take an example. For in this patient, the flows are not coming down to zero. That means this patient needs longer time to expire. And one of the ways that you can do is by increasing the flow rate so that you give that extra time during inspiration to the expiration. The second condition is when patient has flow asynchrony. These patients will be very uncomfortable and agitated and will require increased sedation and paralytics. This will also cause worsening hypoxemia due to increased work of breathing and asynchrony. So how do you spot a flow asynchrony? Look at your flow time waveform and pressure time waveform, and as the patient generates more inspiratory flows, more than what ventilator can provide, is going to pull down on the flow limb, and the same thing is going to happen with the pressure limb as well. And as that effort increases, the flows can sometimes become negative as well. The area between the normal pressure time waveform and new pressure time waveform is the inspiratory work that is being performed by the patient. Flow asynchrony can also result in double triggering. Double triggering is nothing but two mechanical breaths during one inspiratory cycle, and thus gives you higher tidal volumes and defeats the purpose of low tidal volume ventilation. So let's take an example. Before the ventilator gives you the breath, the patient has to trigger the ventilator, and the trigger is nothing but slight decrease in pressure or some flows which the ventilator registers and gives you the tidal volume. If the patient produces more inspiratory flow, he can again trigger the ventilator, and that results in an extra breath that is given to the patient, and this results in high tidal volumes. So why would your patient need to increase the flow? Well, there are multiple reasons for it. If there is increased metabolic demand, such as in fevers, patient has severe metabolic acidosis, patient can have stimulation of a bronchial C and fibers and J receptors, as happens in pneumonias, pulmonary edema, etc. Patient can have stimulation of respiratory centers, or patient can have anxiety, pain, airway irritation, and other reasons. How do you fix flow asynchrony? Well, you try to treat the underlying cause, the fevers, acidosis, pain, and anxiety. What you can do is increase the flow rate. So for example, in this diagram, the black arrow is the patient's effort and the white arrow is the ventilator effort, and patient's effort is causing a dip in the waveforms. If you increase the ventilator effort, you should be able to overcome the patient inspiratory effort and normalize the flow rates and give the patient what he wants. The second thing you can do is decreasing the respiratory drive by increasing the sedation. So should you be concerned with high flow rates? Well, there are a couple of problems that can happen with high flow rates. They are not very serious, however, it's worth mentioning. You can have uneven filling of the alveoli when you're dealing with the alveoli with long time constants. Your peak pressures will increase, and this may sometimes result in shear injury to the walls. Increasing the flow rate reflexively increase the respiratory rate as well. So let's understand a time constant of an alveoli. Time constant is nothing but how quickly the alveoli inflates or deflates, and the time required to deflate up to 63% of its original volume. So for this alveoli, it takes around time t to deflate to 63, and again another 63% for the next time constant. When the flow is constant, the time constant of an alveoli is equal to resistance times compliance. So alveoli with high time constant will either have increased resistance or increased compliance, or both. Normal lungs has got time constant of 0.1 to 0.2 second. The high compliance alveoli, these units will empty slowly and incompletely, as shown in this purple. Alveoli with higher resistance will empty slowly but fully if given enough time. So we have three alveoli here: normal, increased resistance, and one with increased compliance, and see how they deflate with time. So you see the normal alveoli deflates much more than the ones with increased resistance and increased compliance. So it is harder for these two alveoli to empty. When your flow rates are high, there is maybe uneven filling of alveoli when you're dealing with different alveoli in the lungs with long time constants. It can result in worsening hypoxemia in a few patients. It also results in increased pressures. Increased peak pressures are not harmful but may result in shear injury to the bronchial walls. And make sure that your peak alarm setting on the vent are appropriate. So in this figure, we have got two flow rates. one with a low flow rate and one with a high flow rates. And this changes your I time from long to short. And we got three different type of alveoli, and see how they behave as you give them different time to get filled. So in the first flow waveform, you can see that you give sufficient time for the normal alveoli and alveoli with high resistance to fill in completely, and the same with the high compliance. However, when you reduce the inspiratory time, you can see the filling of the high resistance is severely compromised. There's more air filling the alveoli with high compliance, while the normal compliance is somewhere in between. This can result in uneven filling of the alveoli and may cause hypoxemia, depending on how distribution of your alveoli with different time constant is. Second thing it causes is increased peak pressures, and as you increase the flow, you decrease the I time and you increase the peak pressures. However, the plateau pressures remain the same. Increasing the flow rate, understand that it increases the resistance by multiple means, and we'll talk about this in a different video. This would increase the peak minus plateau pressures, which shows how much resistance is there in the circuit. So how do you optimize your inspiratory flow rate? You watch the flow time waveforms, both in the inspiratory wave and the expiratory wave. If you see a dip in the inspiratory wave, that means patient is flow hungry and you want to increase the flow rates. If you see the expiratory time and the flows are not returning to zero, that means the patient has some degree of auto-PEEP and may benefit from giving him a little additional expiratory time, which can be easily achieved by increasing the flow rate. Let's talk a bit about expiratory flow rates as well. Now, expiratory flow rates are passive on the ventilator and only depend on the time constant of the alveoli. You have to watch out for the kinked and ED tube blocks as well, as they will increase the time constant of your circuit. Let's have some visual understanding of this. If you look at the volume time waveforms, in patients with obstructive alveoli, you can see the increased time constant. If you've got stiff alveoli, the time constant is much shorter. And if your alveoli are highly compliant, the time constant will be longer as well. How do you optimize expiratory flow rate? Well, you cannot control the expiratory flow rates, so make sure that there's enough time to expire and you monitor for the auto PEEP. You want to treat the underlying conditions such as tube blockages and COPD exacerbations. So to recap, you watch out for the flow time and the pressure time waveform, and if you see a dip in the flow time wave, you're flow hungry and you increase the flow rate. If your expiratory flow doesn't come back to the baseline, you think you are possibly dealing with auto PEEP, and that can be given some extra time to exhalation by increasing the inspiratory flow rate. While you're doing this, keep an eye on the peak pressures, which can increase and might have to change the alarm settings. Also, watch for the alveoli with long time constant, which can sometimes result in hypoxemia. Thank you.